All right, folks, how we doing? My name is Jared Liebhart. I'm coming to you live and direct from Swedish Cherry Hill, and I'm going to talk to you guys a little bit about Coach CDA, kind of run you through my experience doing a patient workup and case study for that particular exam sequence. So before we get started, we'll just jump right into kind of what exactly a stroke is and get a little bit of background on that. So as we know in our class, we talked a little bit about strokes. Some information for you all is, according to the American Stroke Association, which is a division of the American Heart Association, a stroke is a disease of the arteries leading to and within the brain. Um, Research shows that as of 2020, it is actually the fifth leading cause of death in the United States, but it's also a major cause of disability in the United States as well. So, stroke doesn't necessarily kill everybody, but those that do survive oftentimes will have some residual disabilities from the damage incurred during a stroke, which is unfortunate. Um, Essentially, a stroke occurs when the blood supply to the brain is disturbed by a blockage in the vessel or within the vessel, or when the vessel is ruptured and or burst, such as like within an aneurysm. So, in the when there's a blockage, that could be an ischemic stroke. So you might have something in the way that kind of occludes the blood flow, preventing it to reach the brain. Or in a hemorrhagic situation, you're just getting blood is just basically leaking out of the vessel itself, and it's not reaching the tissues that it needs to. Either case, oxygen is not getting to the brain cells, and that eventually will cause cell death. As we know, blood is the main delivery system for oxygen. Oxygen is a very vital component to the functioning of most living things, including our brain tissue. So it's important to have that. We don't have your brain uses up a lot of nutrients, including oxygen. So you need that constant supply running through the tissues. And if that's for some reason or any reason interrupted, problems can definitely occur, such as cell death, which is basically it's a result of the malfunction of the brain and cause very serious permanent damage, as I've got written down here at the bottom. It kind of goes without saying. But eventually, body systems break down. So your brain is sort of the control center for everything else in your body. So the part of your brain that is controlling how you breathe, that would be a problem. If the part of your brain that controls locomotion is damaged, that can definitely affect your mobility. Part of the brain that affects memory is damaged or doesn't get enough oxygen. That can obviously have some pretty serious consequences as well. So kind of get the idea of why we need oxygen to the brain and why a stroke can be a pretty serious thing to have, and why you'd want to get that addressed quickly. Couple more fast facts. This is from the CDC. So in the U.S., stroke occurs every 40 seconds, which if you think about it, is pretty. It's a lot of strokes. There's a lot going on there. 140,000 deaths a year from stroke. And like I was saying earlier, death is not always the end-all, be-all. A lot of times survivors will have some pretty significant disabilities associated with strokes as well. In fact, of those over 65 who do survive, half of those people will have some pretty significant mobility problems, for lack of a better word, moving forward. 87% of strokes are ischemic, so that can be, again, an ischemic stroke is caused by either thrombus, an embolus, which is essentially a thrombus that has left its original location and lodged in a remote area, or a lacunar stroke. And another fact that I didn't really know, which is important to think about, is patients who arrive in medical care within 3 hours of their first symptoms have less disability 3 months later than those who receive delayed care. And what that really just says is that, and we talked about this in our discussion a couple of weeks ago, that time is of the essence when it comes to stroke. So the quicker we can get patients the care that they need and get them addressed and diagnosed and treated, the better their chances of survival are going to be moving forward. So let's jump right into the case study. So our patient here did come into the ED at Swedish Cherry Hill in the wee hours of July 31st, 2020. According to the chart, the patient had began to experience the symptoms around 4:30 a.m. that morning. The symptoms being right-sided weakness, slurred speech, and altered mental status. I'm not quite sure why, what led to the gap there between when they started noticing the symptoms and when they arrived at the ED, but it looks like about 4 hours had passed, which, that can be pretty serious if it was, a major stroke. So, but that's the way it goes sometimes. I don't know if this patient was aware of the signs and symptoms and realized that she may have been having a stroke, or if somebody else had kind of guided her to seek medical attention. I'm not quite sure about that, but she did arrive here about 8:30, and I believe at that point either the ambulance team or the ED team here had made the choice to call a code stroke when they arrived, and that's kind of how that goes down. We do a lot of strokes here at Cherry Hill. This is one of the stroke centers of the region, so we have a pretty good, pretty streamlined process when it comes to diagnosing and getting strokes on the CT table and scanned. It's something that we practice. In fact, we've been practicing a lot lately, just to kind of work out the kinks in the system and make it as efficient as possible. So we're pretty quick about that, and we definitely are aware that the sensitivity of time here. So we did the best we could. We got them on the table, and they were scanned as quickly as we could get them there. The reasons for the CT order itself. So according to the patient's chart, the CT scan was the first imaging order that was placed by the providers to diagnose or rule out the possibility of a stroke. Given the specifics of the situation, it did seem appropriate that the CT scan would have been the first kind of route as far as imaging goes. Again, that just goes with our stroke, kind of our I guess, in-house stroke protocol. I want to say departmental, but it's kind of interdepartmental since it's really the ED department and us working together. But that's sort of how it goes. We just, anytime there's a possibility of a stroke, based off of the symptoms that the signs and symptoms that the patient presents, we will move into a stroke protocol. So that was the first one. And the reasons for this are pretty, kind of, I guess, to me, straightforward. Maybe I shouldn't say obvious, but, the thing about a CT is they're a lot faster than MRI. MRI is going to give you a lot of great detail. I don't know for sure, but perhaps maybe, according to some, better than a CT. But as we know, MRI process takes a long time. The exam itself can be upwards of a half hour, depending on what you're scanning. But then you have to go through the screening process, since it is like a highly, magnetized situation. You can't have any metal on there. And the thing about a CT scan is, that they're very quick. We do a head CT scan without any contrast in less than a second. Once they're on the table. So we use a GE Revolution at Cherry Hill. It's very fast. Head can get scanned right away. And we always have someone staffed here. I don't know for sure if they have anybody staffed 24 hours in MRI, but I know that CT is staffed 24 hours, and so there's always someone here to get, to run the scan and get that thing going. X-rays, can be used, but they're definitely not going to give you as much information or detail as a CT scan would. And same with ultrasound. I don't know much about ultrasound. I'm not sure if you could even do an ultrasound on a head, but yeah, so to me, the speed and efficiency are kind of the main kind of components that make a CT scan the preferred kind of imaging modality when it comes to a code stroke, and that's what we did. So moving forward, let's take the next slide here. So talk a little bit about our protocols, our CT imaging protocol here at Cherry Hill. So we're, like I said before, we're kind of considered one of the premier stroke hospitals in the region. We have a multi-phase code stroke CVA protocol, and it does not change with age, referring to the kind of the question that was a part of the assignment there that I know of. And most stroke patients are going to be older, so I think it's kind of intuitive to think that the age would not be a factor. I could be wrong. I'm still new at this, but maybe Lori has something to say about that. But yeah, in this situation, age did not change the protocol. First thing we're going to do right away is a CT head without contrast, and that's going to allow the providers to differentiate between an ischemic and a hemorrhagic stroke. So what kind of stroke are we dealing with here? They're going to be able to diagnose and rule out the intracranial bleeding, assess the cerebral circulation, and assess underlying disease. So that comes right out of the book of kind of like what a head without CT is going to offer you. Again, we do ours in less than a second, so they're pretty quick. The next thing that we'll do, once the doctor kind of reviews that head without and decides that they want to move forward, we'll go into a CT angiographic study, and that's going to be a CTA head and neck. So that's going to scan both the head and the neck, and we're looking at the blood vessels there. So we're going to be using contrast for that one. And generally we use the Omnipaque 350, 100 to 150 cc's. I've seen we usually load 150 cc's into the actual power injector itself, and we use about 100 ml of saline as well. So that's how that goes. And then what that's going to offer you is just going to further assess in greater detail the state of the cerebral circulation and brain tissue. It's going to kind of help identify maybe some occlusions, any blockages, things like that. And then we also do a perfusion study as well, and that is going to offer some information to kind of calculate the regional blood flow and the regional blood volume, as well as the mean transit time in the cerebral vasculature. Again, that comes from our textbook. So that's kind of what we do there. That's our protocol. And then we also, as with any kind of CTA head and neck, or any angiograph head exam we're going to do, there's going to be a two minute follow-up delay, a 2-minute delay scan, which we were able to do for this patient as well. Prior CT imaging on the patient, so there was no allergy. So that, when you're going through this thing, obviously a stroke is kind of an emergent situation, so you don't always have the luxury. I mean, we'll usually get a page, so we'll know that they're coming, so we'll have a chance. But we don't always have a patient. We don't have any information on who we're going to be receiving, so it's hard to look into a chart. But if we do have the opportunity, you always want to check out, allergies, make sure that they can tolerate the contrast, and if not, we start looking at some pre-medication stuff, or maybe alternatives. We have Omnipaque, but sometimes we'll use Visipaque if it's someone that's a little more sensitive and can't quite tolerate it. So we did not have, our patient did have a CT performed at Cherry Hill, and so that was there for us to kind of reference, and you'll see as we go moving into the findings that the doctors were referencing those earlier studies. Again, because the patient could tolerate the iodinated contrast, we didn't do any pre-medication, but I wanted to kind of include what our protocol is here. It's very similar to what we learned in class. We're going to offer 50 milligrams of prednisone 13, 7, and 1 hours before the injection, plus diphenhydramine. So Benadryl is going to go in at 50 milligrams 1 hour before the injection. And then there's an alternative, which would be 32 milligrams of methylprednisone 12 and 2 hours prior to the injection, plus the 50 milligrams of the Benadryl 1 hour before. We didn't need to adjust any scan parameters that I was aware of. I wasn't actually here for this exam, but speaking with the techs that were here, they said no. I'm not sure how routine that is on a code stroke when it's a pretty emergent situation. I would imagine if they have the opportunity to, if there's a special circumstance, they definitely would. But we didn't in this case. And we used the GE Revolution as far as iterative reconstruction goes. ACER is a part of that program, and that was definitely used. It's actually, they made a note of it in the findings and the report of the exam as well. So used the iterative reconstruction, didn't use shielding, and no scan parameters were adjusted in this one. And we'll look at our findings and diagnosis of the symptoms. So with the head without, they didn't really see anything significant, basically. So no intracranial abnormality, no evidence of acute infarct, hemorrhage, or mass lesion. So everything, I think, what does it say? Most consistent with leukoencephalopathy. Okay, I can't speak, but definitely some pathology going on there that they found, but with the head without, but no hemorrhages or anything like that. That was that was discovered in that initial scan of the head. And then CTA head and neck there. Honestly, I just kind of pulled these right off of the order. A lot of this stuff I don't know what a NASDAQ criteria is, but it looks like basically in the head they found that there was some diffuse stenosis, some diffuse irregularity, some stenosis inside those like the cerebral arteries and whatnot, and kind of in the circle of Willis area. There was definitely some kind of stuff going on there. So, like I said here at the bottom, overall it appears the patient was suffering from some sort of intracranial pathology. Atherosclerotic disease or vasculitis was what the radiologist had put down as a possibility for what's going on there with that patient. Follow-up post-CT. So we did the 2-minute delay scan, which is really just part of the protocol. 6 hours after the initial code stroke, we had they did an MRI, which I did follow that up. I won't include it just for time, but it did find there was a little more detail found in that study of the MRI. But and then we did another head CT without contrast 4 hours later after the MRI. No biopsy or drain was performed on this patient. And lastly, what did I learn? Well, I really enjoyed doing this project. I do have the luxury of working at in a CT department with some great staff members who were able to kind of help me out with these things and kind of shed some light on stuff that I don't quite know. But I learned a lot. I certainly learned more about strokes doing this. So I had a kind of a rough idea of what a stroke was and kind of what it is, what goes into it, or what the causes and whatnot. This just offered me an opportunity to kind of dig a little deeper and get more familiar with that. And because I'm at a stroke center, or what may be considered a stroke center to some, this is good information to have. So it definitely worked out well for me to have this kind of this study on my plate to tackle. Helped me kind of learn how to track a patient from the beginning to the end, as far as going back and checking out, all the events that took place from getting the patient into from the ED, kind of assessing the signs and symptoms and kind of just what goes in the processes of decision making in terms of how to treat them next, or, how to order images. It was really interesting to see, why we do CTs over MRIs or X-rays, which, like to some may seem obvious. It wasn't to me. I didn't know. I thought maybe, oh yeah, MRI would be great, but it takes a lot more time and all that good stuff. So it definitely helped me track that, or learn how to track the patient from beginning to end, how to research patient history, how to get familiar with, we use Epic at Swedish Surgery History, how to work that out, and how to properly work up a code stroke patient. That was another great thing that I learned. So we also learned some new terms and did some pathology that I hadn't been familiar with previously. So overall, it was a great experience doing this project. I want to thank everybody who stopped by and gave this 18-minute PowerPoint a listen, and I hope you learned something. And I look forward to checking out your guys' projects as well. So all the best to y'all, and we'll chat again later. Take care.